first floor. And you can see this is the setup. It is the bed end, this is the tail end, is the leg side, right side. And starting on the right side, you can see we have kept the plasma, the RF and coagulations on the right side.
49
We work on the left side.
হ্যাঁ ভাই ওটি হাসপাতাল চালু করে নি
This is the lumbar spine. You always need to mark the complete level. This is the midline. This is the L5 pedicle and this is the S1 pedicle. I have marked the pedicle, and as this disc is increasingly migrated, I slightly would like to take the incisions inferiorly, and here is the midline here, and here is the discal line which we have confirmed it in Siam. We have confirmed the level. It is inferiorly migrated disc at L5 S1, and we will check it, confirm it so that we can do our planning. If you have any questions, you can ask me. We can discuss and proceed. We can stop the video. That's possible. What I am saying, this is what I have identified, and this is the dance of the chopsticks. Some amount of multifidus is being taken away from the laminar sheath, inferior lamina. This is very important to confirm because sometimes we can go on the opposite side and we don't realize it. These are the sleeves which we are attaching. Always check the white balance and the water flow. These were very important steps again of checking the inflow and the outflow so that the water goes in, gives the clear vision, and you are out. The water is, saline is coming out. You need some amount of ablation, RF. This is how it looks when you are entering inside. And then you hit some tissue, either soft or hard. If it is soft, it's an interlaminar space. If it is hard, you are on somewhere on the bone, most likely superior. To simplify, I just confirm it, my level again. And this is the inferior lamina, which I am doing ablation. RF. I just need to take out some portion of the inferior lamina here. Creating a window is very important. I am palpating. This is mark. Soft tissue, laminotomy, flavectomy, disectomy, all the top. Step by now I am using the burr. I have to be gentle because here I am using the burr with one hand. We are normally used to use both the hands while doing the burring because that's better controlled. But you have to be very careful in the initial phase because you might go inside the interlaminar space and that's a disaster. You have to be
on the constant focus. Your mind should be focused, and you should have the tactile feedback of the bone where you are burring. You are burring the bone. You are on the bone. You are not doing anything on the soft tissue. The minute you feel, you stop. You stop the acceleration of the burr. Because some burrs are very high intensity, and be gentle and careful. At the same time, be away from the endoscope. Now I am using my curate, which is my favorite instrument, because curate is very safe when you are trying to renew the surface, and under the ligamentum flavum is attached underneath the lamina. Gently you are just curating. You are just trying to get the interface, and slowly you are trying to go up. And layer by layer you are just trying, and outer cortex and then inner cortex. If you feel, you can still do some amount of burring. And then once you are comfortable, then just ligamentum flavum is acting like a candy for you. It's a safety zone for you. And then you just do, I do mixed curate and caries and round jaw. Some people are talking about only punch, but I think it's not feasible. It's more safer to use garrison. But bite it, not pull it. Most important, it should be a biter. Just bite and you have the bone inside. That's very important. Don't pull, because there are various ligaments of the dentate, the Hoffman's ligament. Anything can pull the dura, and by the time you open, you feel there is a dural tear and you are in disaster. So I am seeing something glistening greyish white structure there, and that's my dura. I need to go there. I was just separating my ligamentum flavum, which is a attachment underneath. And this is like under the cave. I am just going inside and I am working here. And I am quite safe now. I know where I am. I am just trying to take bite by bite, one at a time. No need to rush. I can see the pulsations of the dura. And the only yellow ligament in the body is the ligamentum flavum, as it's a Greek word. Flava is yellow, therefore it is called as flavum. And we are just trying to take bit by bit, and very carefully we are biting it. You will see that layer of fat glistening, golden yellow. And wherever you feel you are not getting a better access, use your burr or curate to make it more simplified. You can see the epidural now. I am on it. I think no one can show such beautiful pictures. On the best magnification, you can see the traversing route is already started. See, you are on the lateral sheath of the dura, and you are using your coagulation for the vessels. And here I have reduced my complete intensity. It is 2 and 2, and when I started it was 9 and 5. The ablation was 9 and coag was 5, but I have reduced it because I am on the neural and dural structures. As I mentioned earlier, dysesthesia is a very dreaded complication which we don't realize. Patient keeps talking about numbness, tingling, paralysis. We keep telling, "Sab theek ho jayega," but it's a mistake which we have done while doing it, because we were not careful while using the radio frequency, and we were also You can see a beautiful root. It's slightly swollen and inflamed because the disc which was pushing. And here the water washes out everything. That's the beauty. The prostaglandins, the interleukins, whatever is released during the disc extrusion is washed out, and that's also a natural saline effect of the endoscopy, which is added up here. And you can see the vessels beautifully. I like to stand on the right side for a right-sided disc, but one can do it from the left side also. But I think right side you can have a better nerve root clearance till it exists from the foramen. You can always do over the top, that's not a problem, from opposite side, the contralateral side. And this is the beauty of magnification, around 30x, microscope is 10x, loop is 3x, 2.5x, and this is almost 10 times the magnification of a loop. Unmatched beauty. You can actually see the RBCs, movement of RBCs with biportal. We have the videos. So beautiful because it is really, you can see the movement. Is it important? It's actually not important, but the vision is very good, magnification is very good. And when do we stop? So you can see I am getting a large disc extruded inferiorly. I am taking out the disc fragment by fragment. I am trying to not lose my patience because it's quite a large extrusion. And I am not biting any annulus, I am just using my disc forceps and taking out all the shredded fragments inside. And if you see, I am using all the standard instruments what we normally use in a micro discectomy or open surgery. But now they are coming up with a lot of fancy and advanced instrumentation you can use. And as I mentioned, the next topic was the over the top. We will be covering up over the top also in the same topic because it is naturally it will cover up. And now if you see, I am going across, it's on the top actually, I like to use the word in biportal, it's on the top, it's not over the top. Over the top is like in tubes, where you are turning the table, putting the tube, changing the angulation, all these things not required. If you are on the top, you see both sides, absolutely beautiful, you can see the traversing route of both the sides. Therefore, that misnomer term we are changing to on the top decompression. I am on the opposite side, if you can see, and I am going carefully. I am using my hook probe. And then I am putting free and happy root. This is my fellow, I will acknowledge him also. And this is the incision and post-operative X-ray. You can see some amount of laminotomy, and this is the post-operative picture. The inferiorly migrated complete fragment is